This is going to be our PowerPoint for Chapter 20 for endocrine and hematologic emergencies. We're going to be doing it probably in two parts. Part one will be the endocrine emergencies, and then we'll do a short PowerPoint for hematologic a little later. We're going to move right along and know that we're basically, when we're talking about endocrine emergencies, we're going to be talking about diabetes and that type of thing. We're going to talk about long-term effects of diabetes, as well as acute diabetic emergencies that we may or that we will be dealing with in the field. And then later on in the hematologic portion, we'll be talking about sickle cell crisis and clotting disorders and how to deal with that. So let's get into it. We know that our endocrine system directly and indirectly influences basically every function in our entire body. Endocrine disorders they come with a multitude of different signs and symptoms. Like I said, we'll be primarily focusing on blood sugar today, and we'll talk in our next portion about how hematologic emergencies are difficult to assess and even more difficult to treat. So basically, what is the endocrine system? It is the communication system that controls functions inside the body. It controls all types of things, and there are many, many glands involved. But those glands secrete hormones. And what happens is the hormones travel through the blood to the organs or the tissues or whichever cells they affect. And you can develop disorders because of a disruption in that communication. Like if one of the glands is not functioning, it might produce too much or too little of the hormone, or maybe the gland is functioning just like it's supposed to, but the organ or the cells or tissues or whatnot that are supposed to be receiving it and responding to it, they may not be responding. So our brain needs glucose and oxygen to perform, well, just like all the cells in our body, but our brain, we're going to specifically talk about here. All cells need sugar and oxygen in order to perform. And what they do is they take the sugar inside and they use a little ATP, that body's base unit of energy, and they create a little bit more ATP and a lot of waste product. And then they come in with processes called the Krebs cycle and the electron transport chain, and they mix oxygen in with those processes and create a lot of energy or a lot of ATP. So, you know, we talked about in human body, we talked about aerobic versus anaerobic metabolism, and how aerobic metabolism was that metabolism with oxygen, and how that without oxygen, we just get that little bit of energy and from the processing of glucose through something called glycolysis, but we get a little bit of energy and a lot of waste product. Well, if glucose can't get into the cell, then we don't even get that. There's no energy production at all, and the cell can't be fed. So the pancreas produces and stores two hormones. It does glucagon and insulin. And then there are the things called the isolates of Langerhans, and they're found in a small portion of the pancreas. And within they have alpha cells and beta cells, and alpha cells produce glucagon, and beta cells produce insulin, and blah, 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 and so on and so forth. A lot of stuff that, you know, you can research on your own. You're probably not going to have a lot of be subjected to it a lot in the pre-hospital or even inter-facility capacity at the EMT level. But it's good to know that the pancreas produces and stores glucagon, or a form of sugar, or something that can be broken down in sugar, and insulin to aid the process of that sugar entering the cell. And so that's what the pancreas does. It stores them and it secretes that insulin and that glucagon in response to what the level of the blood sugar is. So patients can develop diabetes. And diabetes is a disorder of basically how our body metabolizes glucose or its inability to do so. And without treatment, glucose levels can become really, really, really high because we don't have enough insulin and that glucose stays in the cells or whatnot. If not managed, over a course of time, patients can become blind or definitely have some severe vision deficits. They can develop a cardiovascular disease, kidney failure, or whatnot. And there are three types of diabetes. There's type 1, there's type 2, and then there's the gestational diabetes that happens during pregnancy. But we treat diabetes through patients take injectable hormones like insulin that lower their blood sugar level, and they take oral medications, diet control, and that type of thing, depending on which type you have. And we're going to go a little more into the different types of diabetes now, or in a minute. But we're going to talk about what hyper and hypo is. What you need to know in all this is that hyperglycemia is by definition high blood sugar, and hypoglycemia is low blood sugar. And hyper and hypoglycemia both can occur with all types of diabetes. It doesn't matter if a patient is type 1 or type 2 or even gestational. They can get their blood sugar can get too high or it can get too low. But all hypo patients require immediate treatment. So that's basically letting us know that hypoglycemia is the one that is the most immediate life-threatening emergency. Doesn't mean that hyper or high blood sugar can't be life-threatening. It just simply means that hypo has a quicker onset, and with low blood sugar, there isn't any sugar in order to be able to get to the body tissues in the brain for it to produce energy. So let's talk about type 1. Okay, type 1 is an autoimmune disorder. It is where basically the body attacks the beta cells in the pancreas. And we mentioned the pancreas earlier and how the beta cells produce the insulin. So if it's attacking those cells that produce insulin, eventually the pancreas can no longer produce insulin, and then we've got a lot of sugar floating around in our blood, but we don't have any insulin being produced in order for that sugar to be able to enter the cell. So that's how insulin works. Okay, blood or sugar floats around in the bloodstream, but it can't enter the cells without basically piggybacking and insulin opening the door for it, if you will. So it can bump up against the outside of the cell all day long, but it can't go in unless insulin is present. That's why if we have too much insulin present, then it takes all the sugar inside the cells, and there's none in the bloodstream for our body to continue using. It has to be regulated pretty specifically. So for diabetes type 1, this is the failure of the pancreas to produce insulin because the body's attacking those beta cells, and the patient has to get insulin from some external source. So these are the patients that take insulin every day and sometimes several times a day, and without that insulin, they cannot survive. Whereas type 2, we'll talk about, you can actually take, it can be more oral medication or diet controlled, might have some insulin with it, but type 1 diabetics have to have insulin on a daily basis because their body's not making it. So a lot of them you see will have an insulin pump. It might not be noticeable. They might wear it under their clothes or on their belt and that type of thing. But what that does is it continuously measures the glucose levels and provides the appropriate amount of insulin. The one thing we want to remember is that if we check a blood sugar on a patient and that blood sugar is high, then you would never, ever, ever try to adjust their insulin pump yourself. If their blood sugar is really low and the insulin pump seems to be working, seems to be on or whatnot, it's one thing to turn it off or to pull out the needle, the small needle that's actually inside the skin, piercing the skin, but we never, ever, ever touch it for any reason with a patient with high blood sugar. So an insulin pump does limit the number of times a patient has to check their blood sugar all during the day, but can malfunction, dump too much insulin, and cause low blood sugar, or can stop producing enough insulin and the blood sugar get higher. But you would always inquire about the presence of an insulin pump even if you don't see one. So diabetes type 1 or type 2 type 1 diabetes is the most common metabolic disease of childhood. And basically the symptoms that start out are polyuria, which is increased frequency in urinating, polydipsia, which is increased thirst because our body's trying to flush that sugar out. So we get thirsty because we're urinating more. Polyphagia, they have a tendency to overeat, but at the same time, even with excessive eating, we have weight loss, and then there's the fatigue. Normal blood sugar, you need to write this down and remember it forever and always. Normal blood sugar or glucose level is 80 to 120 milligrams per deciliter. That simply means 80 to 120 is our golden or our sweet spot. That's where we want to be. It doesn't mean that patients don't get slightly outside of that range. You probably get slightly outside of that range at times, but we don't treat blood sugar issues typically until they're below 60. So once again, normal glucose level is 80 to 120. We typically don't treat until it drops below 60. But when a patient's glucose level is above normal, the kidneys become overwhelmed because glucose spills into that urine. And so that's where the frequent urination comes from. And our body gets fluid from wherever it can. We're constantly thirsty, putting fluid on. It's pulling fluid out of the cells into the bloodstream. So there's more fluid there for the kidneys to be able to try to flush out that sugar. So problem is when glucose isn't there in the cells don't just like take a coffee break or give up. They say, okay, well we got to use what we got to use, so we're gonna burn fat instead. But instead of the normal waste products that we would get from using sugar and oxygen as energy, burning fat, which relates to that weight loss we talked about just a second ago, even with the overeating, that fat produces a waste called ketones. And ketones is an acid. And that ketone, the ketone levels increase, they go up in the blood, and the kidneys become saturated with sugar and ketones, and they can't maintain that acid-base balance in the body. And acid-base balance is a pretty fine line. If we look at a pH scale that we've all heard of that goes from 0 to 14, a human being is not just 7, but 7.35 to 7.45. That's a very small range. And our body is constantly trying to maintain that pH level of 7.35 to 7.45. So if our body becomes more acidic, then our body's pH is dropping below 7.35, and we don't have to go far out of that range for us to be very, very sick and possibly die. So with increased blood sugar, we produce those ketone. Then there's no. I'm sorry. All right. With increased blood sugar, that means that the sugar is in the blood and not in the cells. So the cells burn fat, and they produce the acid ketones. And then the kidneys become saturated with the excess sugar it's trying to get rid of, and the ketones or whatever can't maintain the acid-base balance. And so our body could go into something known as diabetic ketoacidosis that we'll address here shortly. But the patient starts breathing faster. These are fast, very deep respirations. They're known as Kussmaul respirations. That's one of the respiratory patterns should have covered in respiratory respiratory emergencies, and that you should make sure you're aware of. So if that we keep burning fat and the ketones keep being produced or whatever, then there's that DKA. And DKA is a very serious condition. It can start off with people just feeling bad. And remember that high blood sugar is not something that happens, in 5 minutes, 15 minutes, or, a day. This is something that our blood sugar gets higher and higher and higher. And we get these symptoms developing over the course of days, possibly weeks, and even possibly months. But we note that our patient doesn't feel well, they're tired, maybe some body aches, start having some abdominal pain and some nausea as it progresses. And then it can actually get to the point where our patient can be an altered mental status. We know is anything that's not normal. They could be confused or whatever, all the way to a coma-like state, being completely unconscious. Generally, you're going to have a blood sugar and DKA of greater than 400. We're going to find that by using our glucometer that we did during vital signs. And now we're going to talk about diabetes type 2. It's not nearly as involved. It's basically our body's cells become insulin resistant. So people that are overweight end up being predisposed to it because our pancreas, we have more tissue, there are more cells, more cells need more sugar. More cells would require more sugar. And so then more insulin has to be produced or whatever. And eventually the pancreas just gets overworked and it can't keep up. So people use oral medications to treat diabetes, like metformin and glucophage, things like that. And but they also use injectable medications, and you do see some type 2 diabetics that use insulin just like type 1. But it's always a good idea to ask the patient what type of diabetes they have. That's not going to change how you treat the emergency that's presenting itself, but that is something good to know for your history taking. And most people, when they get a yearly physical or whatever, the blood sugar levels becoming high or being high when fasting and things like that can trigger healthcare professionals to telling someone that they're pre-diabetic and watching the development of the disease into full-blown type 2 diabetes. You might find patients get recurrent infections. They might have vision changes, numbness in the feet from a condition called neuropathy. So let's go back to hyperglycemia. Let's talk about it a little more in depth. So it occurs when our blood glucose levels are high. Anything above 120 is considered hyperglycemic, but we don't consider it, life-threatening or severely damaging until we get much higher. In patients that has an altered mental state resulting from several combined problems in type 1 diabetes, this can lead to the ketoacidosis we talked about. And then in type 2, it leads to non-ketotic hyperosmolar state of dehydration. So to break that down, we already talked about the DKA, or the diabetic ketoacidosis. That's a big old word, the non-ketotic hyperosmolar state of dehydration. All that simply means is that when I told you the body could become dehydrated, it's literally our body, it's not the burning of the fat and the production of ketones. It's actually the opposite. So in order to get that blood sugar, the sugar that's inside the bloodstream actually is sucking water out of the cells and dehydrating us on a cellular level. So anyone who has long-term hyperglycemia, they might end up having wounds that don't heal. You see a lot of our elderly population going to, they're very careful, because if they get injured and they have a wound, especially in the lower extremities, it's hard for these wounds to heal because they don't get the circulation they should. They have the neuropathy, the numbness in the hands and the feet, may develop blindness, go into renal failure, and end up on dialysis. And they actually can even develop gastric motility problems, or the digestive process of our body moving waste product through and creating stool. So when the hyperosmolar hyperglycemic non-ketotic syndrome develops, remember that word, or don't, just remember HHNS. What's happening is we are being dehydrated at that cellular level. We have hyperglycemia. We're going to be lethargic, or very drowsy, be altered in some way. There's going to be severe dehydration, because our body's not going to be able to take in enough fluid, and it's pulling that fluid out of the cells, and our patient feels like crap, and then they end up altered or whatnot, when they're urinating, because their body's going to continue to try to urinate frequently. That urine is going to be dark in color. They may start having those visual issues that we already talked about, may actually start having some partial paralysis and weakness, which we might say, oh no, this patient is having a stroke, because it does mimic a stroke. Or they may have actual seizure activity because of electrolyte imbalances. So that once again, we mentioned that increased fluid intake, the polydipsia and polyphagia, increased food, leading to the polyuria, the increased urine output, whatever, concentrated urine. And patients that are having seizure activity are on the backside of that. And this is when hyperglycemia is a true emergency, and we want to transport rapidly. Hypoglycemia happens much faster. This can happen in anyone who takes any kind of oral medication. Maybe they took their insulin, but they didn't eat. Maybe they took too much insulin. Maybe something happens, some metabolic issue, and the glucose is rapidly taken out of the blood for another reason or whatnot. But regardless, when glucose levels fall, then there may be an insufficient amount to supply the brain, and these are the patients that are going to go unresponsive very quickly, or they're going to become altered very quickly. We're going to mention it again shortly in the treatments, but always remember that we treat hypoglycemia at the EMT level by administering sugar orally or by mouth, and we would never, ever, ever give a patient anything by mouth if they were altered and cannot protect their airway. So in hypoglycemia, mental state, the patient declines. This can happen very rapidly, and the patient may become aggressive, actually appear intoxicated, angry, confused, display unusual behavior, mimic stroke-like symptoms, or they may become unconscious, and at that point, permanent brain damage can quickly follow. So common reasons for our blood sugar to drop. They gave the correct dose of insulin, but they changed their routine, didn't take it exactly at the same time. Maybe they took more, like we said before, they took their insulin, but they didn't eat, or they took their insulin and maybe they have some type of illness. We know that even along with insulin, certain medications that were given for other conditions actually affect blood sugar. You may get people with respiratory issues, or even get someone who has poison ivy might go and get a steroid, and steroids can throw blood sugar way out of whack. Antibiotics can also affect our blood sugar levels. Excuse me. So signs and symptoms are going to be normal to shallow respirations. You might find patients that are lying there, if they're altered and they're snoring, their skin's going to be pale, clammy, or they could be really diaphoretic, really sweaty. They could be complaining of dizziness or a headache, could be completely unresponsive, could have a rapid pulse, could have a normal blood pressure to a low blood pressure. Blood pressure is not going to be high. If this continues on, and this, like I said, it doesn't take long, they could develop anxious or combative behavior, might actually go completely into a coma, or faint, have seizure activity, weakness on one side of the body, mimicking that stroke. But those mental status changes can happen very, very rapidly. So if we arrive to a patient that we believe might be having some kind of diabetic emergency, we want to quickly check blood sugar. So if our patient can maintain his airway, we can give that oral glucose before he's unable to do so. And there's a scale for the different conditions and whatnot. This says hypoglycemic crisis below 50. We typically use the number 60. So we know how to size up a scene with our 5 parts: our scene safety, our PPE. We check the number of patients. We determine, is this a mechanism of injury or nature of illness, or a combination of the two, and we determine if we need any additional resources. If we believe this to be a hypoglycemic emergency and our patient's unconscious, and we know that we wouldn't be able to give anything orally, it might not be a bad idea to go ahead and have some an ALS involved and on the way. So we'll get our general impression. We want to know, is there anything surrounding our patient that looks out of the ordinary? Are there syringes? Do we see insulin? Insulin's typically kept in a refrigerator, though. Do we note any kind of trauma, any bleeding, anything like that? And we want to make sure that when we check our airway and breathing, we're making sure that airway's patent. In an altered patient, we may have to maintain it for them. We want to make sure that they're breathing adequately, getting good tidal volume on their breaths, have a good respiratory rate. But we also want to throw a pulse ox on them. And if our patient is below 94%, we won't want to consider throwing some high flow O2 on them, 15 liters a minute with a non-rebreather. With hyperglycemic patients, you may have those Kussmaul respirations we mentioned earlier, but we didn't mention with the diabetic ketoacidosis the sweet, fruity breath. They may have sweet, they may appear intoxicated, but you won't have the smell of alcohol in the breath. You'll have more of an acetone or a sweet, fruity odor. And by acetone, I mean like almost a nail polish remover type smell. And hypoglycemic patients or low blood sugar patients, they're not going to have Kussmaul respirations. They're going to have normal to shallow and rapid respirations. With high blood sugar, we're going to have dry, warm skin. With hypo, we're going to have that pale and clammy. And we could also, with hypoglycemia, have that weak, rapid radial pulse. So once you determine your patient's condition or whatever, it's time to make a transport decision. Remember, we might have already gotten ALS en route, but we might need to go ahead and, be managing that airway, supporting ventilation and circulation to the best of our ability. And and if our patient's conscious and capable of swallowing and maintaining an airway, we might want to do a further evaluation for treatment. Obviously, we're going to obtain a history if the patient can answer us, or anybody around can tell me if the patient has a history of diabetes. That's exactly what we want to do. It gives us clues us in to go ahead and check a blood sugar even faster. But if the patient's eaten and not taking insulin, high blood sugar is more likely. If they're taking insulin but not eating, obviously low blood sugar would be more likely. It's kind of common sense. We know our sample history. We have signs and symptoms, allergies, medications, past medical history, last oral intake, events leading to this. Do you take any type of medication to lower your blood sugar? Do you wear an insulin pump? Do you take insulin? Have you taken it today? Have you eaten normally a day? When was your last meal? And so on and so forth. Physical examination, we can assess them from head to toe. If there is a possibility of trauma involved, if you believe that if I check a blood sugar, my patient's blood sugar is low, I don't necessarily need to do a complete head-to-toe trauma assessment. I need to focus on my airway, breathing, circulation, and treating the diabetes-related problem. In our vital signs, we're going to make sure we include that glucometer. We may have hypoglycemia, which is going to be below, if it's below 60, we might need to treat it. And we would do that with something orally. Hyperglycemia, not a lot we can do for that. We can get them to drink fluid, but they're going to need IV fluids and insulin. And we know our ranges. We already talked about a glucometer should read 80 to 120, or with a neonate, a newborn, it should be at least 70. Reassess frequently because blood sugar can go up and down quickly, and we would administer that sugar we were talking about orally. For hypoglycemic patients, they need IV if they're altered and there's a risk of aspiration. They're going to need IV glucose, or they may need IM glucagon to help raise their blood sugar. But anytime we're in doubt, we're going to consult medical control. If we can't test for a glucose value, we're just going to perform a thorough assessment, contact the hospital, tell them the signs and symptoms, treat accordingly. If you have someone who is altered, they say they don't, or a little altered, they say they don't feel well and they have blood sugar issues, if their blood sugar was high and you were to give them sugar, that's not going to really make their situation any worse. So if in doubt, always administer some sugar. But typically you're going to have a glucometer available, or at least there be someone else close by with one. Remember, patients can have glucometers as well, and we can use their equipment if ours were to fail. Patients who we give a little sugar, they feel better. They may say, no, I feel better now. I don't want to go to the hospital. Remember that you're going to want to document that extensively. And also, if you give anyone any type of sugar, like anything sweet, juice-wise or whatnot, that's only going to last for a short period of time. So that patient needs to go ahead and start eating something with some complex carbs in it, something heavier, anything from peanut butter, mac and cheese or whatever, something that's going to sustain them for a while so that we don't have a recurrence of the same issue. There's the oral glucose we give. It's called glucose 15. We give 15 grams right there in the name. However, it doesn't always come in a gel. Sometimes you'll find that we're carrying chewable tablets, or sometimes patients have chewable tablets of their own, or there could be a liquid formula that we use. We back to what we said way earlier, the biggest contraindication: anybody who has the inability to swallow, or they're altered to the point that they can't protect their own airway. We would never give anything by mouth. Before we put anything in a patient's mouth, we're going to put gloves on, and we're going to follow our local protocols. We're also going to reassess frequently, checking the blood sugar every few minutes to see if it's rising or not, and that can determine how quickly we need to transport. Presentation of hypoglycemia. We mentioned earlier that there could be seizures. If our patient is having seizures, or if we walk up on a patient who we got called out for seizures, we don't necessarily know that patient has a seizure disorder. It could be blood sugar related. So consider that in all seizure patients, that hypoglycemia can be an underlying condition. If you watch the or read the PowerPoint for neurological disorders, one of the things that we always do for all seizure patients is check blood glucose as soon as we can, or as soon as the seizure subsides, because we can burn a lot of sugar that way. Obviously, we're going to ensure that an airway is clear. Place the patient on their side in a recovery position. Never put anything in their mouth, but always have suction ready just in case. And if we need to raise up that oxygen saturation, we may need to provide oxygen. Or if we know patients don't seize during, don't breathe during seizures, so we may have to give supporting ventilations, and we would always try to transport these patients very quickly. If the patient has an altered mental status, we might want to follow the mnemonic AEIOU tips. I don't expect you to remember this. I mean, it's hard for me to remember. I keep a little cheat sheet, but reasons for an altered level of consciousness might be it might be alcohol related, or it might be an acidotic problem or alkalotic problem, some kind of acid-base balance. Might be an endocrine issue, or for the E, or electrolytes. Insulin, too much or too little for the I. O could be opiates. U, uremia or uric acid. T for trauma. Could be anything from head injury, or they might be bleeding out, hemorrhagic shock. I is intracranial pressure or infection. P is poisoning, or it could be a psychiatric issue. And then S could be that seizure we just discussed, or it could just be a syncope or a episode of fainting. We want to make sure that anybody who has an altered mental status has a clear airway, being prepared to bag our patient or suction if necessary. Transport quickly. Remember that misdiagnosis of any kind of neurodysfunction could be, you could mistake these symptoms for a patient who's just intoxicated. Combative patients, that and the other, whatever, we still want to try to talk them down. They may be very hard to deal with, but try to get that blood sugar as quickly as possible with your glucometer in order to narrow down the causes. A diabetic patient might be combative, like we said, and could be confined by police, but we can look for emergency medical IDs, whether it's a bracelet or a necklace, or maybe a card in a wallet. And we're obviously going to understand that diabetes and alcoholism could coexist in the same patient. So patients who have an altered mental status can lose their gag reflex. They could vomit, or their tongue could be an obstruction. So we monitor the airway, make sure that it's patent, and that we maintain it appropriately. And once again, always have suction available. I will stop here and go into hematologic emergencies in our next slide presentation.